Good morning all. I am Dr.Suresh, Assistant Professor, Department of Oral and Maxillofacial Surgery. I am going to brief something about patient love. These are my contents of the topic. Development of patient love, functional component of patient love, motor route and sensory route of the patient love, surface marking of the patient love, course of the patient love, artery supply and venous drainage of the patient love, branches of the patient loves, patient love lesions, and a level of injury in the course of the patient love and references. So, patient love is a seventh cranial love is developed from the development nuclei of the truncus solitarius is developed from the pontine nuclei and inferior olivary nuclei, motor nuclei, superior salivatory nuclei, lacrimated nuclei. These three nuclei are developed from the basal lamina. Functional components, there are 5 functional components there. First functional component is special visceral or brachial apparent. It is responsible for the muscles of facial expression and also muscles elevating the hyoid bone. General visceral apparent or parasympathetic or secretomotor. It is from the sublingual gland, submandibular gland, glands present in the palate and nose and pharynx. The general visceral apparent brings the apparent impulses from the sublingual gland, submandibular gland present in the nose and palate. Then basal visceral apparent is carrying the taste sensation from the anterior two-thirds of the tongue except valid papilla and palate. General somatic apparent is a sensory to the part of the skin of the ear. It is not giving the direct branch to the any branch to the ear, but it is communicating with the vagus branch. Motor route is responsible for muscles of face, scalp and auricle, especially buccinator, platysma, stapedius muscle, styloid muscle, and also posterior belly of digastric. Sensory route. So sensory route brings the gustatory fibers from the anterior two-thirds of the tongue, soft palate. It gives preganglionic parasympathetic fibers to the submandibular gland, sublingual gland, lacrimal gland, glands of nasal and palatal mucosa. Surface marking. We can mark a point at the middle of the anterior border of the mastoid process. Surface marking, a point at the middle of the anterior border of the mastoid process. The stylomastoid foramen lies 2 cm deep to this point. A sign point behind the neck of the mandible here. So, this distance is the surface marking for patient love extracranial course. Now, we are going to see something about patient love courses. So, patient love attached in the brainstem by 2 roots, motor root, sensory root. So, it attached in the pons by in the lateral and the lower part of the pons deep to the 8th cranial nerve. So, it passes laterally and forwards with the 8th cranial nerve. So, it runs and enters into the internal acoustic meatus and motor root of the patient nerve is grooving in the 8th cranial nerve. And in nervous intermediates or sensory root is present in between motor root and 8th cranial nerve. So, these nerves are accompanied by the labyrinthal vessel. So, in fundus of the internal acoustic meatus, it's a fetus part of the temporal bone. The motor root and the sensory root of the patient nerve it's combined and forms a single trunk here. So, in the patient nerve canal, the patient nerve gives 3 parts by 2 bends. First part passing laterally and above the vestibule, and the second part is passing backwards above the promontory. Third part runs downwards behind the promontory. So, in between these 2 bends we have, first bend is very sharp, so it is called geniculate ganglion. It gives one branch of nerve. The second part is second bend is gradual. Now, after coming out of the stylomastoid foramen here, it runs extracranial course, gives extracranial course. So, it crosses the styloid process laterally and it enters the parotid gland in a posterior surface and crosses the retromandibular vein and the external carotid artery and gives its 5 terminal branches. So, this is a study done by David et al. 1956. His studies gives this 6 pattern of the terminal branch of the patient nerve. This is the artery supply to the patient nerve. First artery is superficial petrosal branch of the middle meningeal artery, then stylomastoid branch of the posterior auricular artery, occipital artery, superficial temporal artery, transverse facial artery, and finally tympanic branch of ascending pharyngeal artery. Venous drainage, this vena committents of the superficial petrosal and stylometal arteries is very important. The branches of patient nerve. So first branch from the geniculate ganglion gives the greater petrosal nerve. This greater petrosal nerve combined with the deep petrosal nerve in the forms the nerve to pterygoid canal. This nerve to pterygoid canal gives preganglion fibers to the phenopalatal ganglion. Then it gives the lacrimal nerve and lacrimal gland. Then sign branch is nerve to stapedius. This nerve to stapedius supplying to the stapedial muscle. This muscle is very important to damp the excessive vibration and sounds. Third branch, cauda tympani branch, about 6 mm above the stylomastoid foramen. This cauda tympani branch gives. This cauda tympani branch combined with the lingual nerve and gives the preganglionic fibers to the sublingual gland, submandibular gland, and also taste sensation to the anterior tooth head of the tongue. So these are the intracranial branches. Then after coming out of the stylomastoid foramen, it gives 3 branches: posterior auricular branch, digastric branch, stylohyoid branch. Then is enter the parotid gland and gives his 5 terminal branches. It's a very important for maxillofacial surgeons: temporal branch, zygomatic branch, buccal branch, and very important marginal mandibular branch and cervical branch. So we can go through the one by one terminal branches, because maxillofacial surgeons doing the many surgeries in the face regions. So terminal branch of the facial nerve is very important while doing the any surgical procedure. So temporal branch. So it supplies to the intrinsic muscles of auricle, anterior and superior auricular muscles, frontal belly of occipitofrontalis, orbicularis ogli muscle, corrugator superciliary muscle. Surgical note: while doing the open approach to the temporomandibular joint, is a more chance of violation of the temporal branch of facial nerve is possible. So if we injure the facial nerve, the patient cannot squeeze the ipsilateral eye or wrinkle the forehead. So these are the temporary weakness. Then zygomatic branch. The zygomatic branch of the facial nerve runs along the zygomatic bone and innervate to the orbicularis ogli muscle. Surgical note: so while doing the open reduction of the zygomatic arch or any surgical procedure for traumatic zygomatic trauma or zygomatic arch fracture, use of Bayard screws or zygomatic hook may be inadvertently damage the zygomatic branch of the facial nerve. So you must want to take care of the zygomatic branch while doing the surgical procedure. Then buccal branches is innervating the money muscles, superficial muscles, procerus, zygomatic major muscle, levator labii superioris, levator anguli oris, zygomatic minor muscle, levator labii superioris alekinesi, and also buccal muscle, orbicularis oris muscle. Surgical note: so any trauma in the buccal region or cheek region, it may be possible for injury to this buccal branches happen. So very important branches: marginal mandibular branch is run along the lower part of the mandible. It and innervates to the muscles of the lower lip. So while doing the surgical procedure in the mandibular angle region or body region for a trauma patient or any other patient, any other tumor surgeries, we must place the incision in the 1 to 1.5 centimeter below the inferior part of the mandible to avoid the trauma to the marginal mandibular nerve. Cervical branch runs downward and innervate to the platysma muscle. So now we can go to the facial nerve lesions. So two kind of lesions happen: one supranuclear lesion, another one infranuclear lesion. Infranuclear lesion, otherwise called as Bell's palsy, it's present in the lesion in the along the course of the facial nerve. So this lesion often means the same side of the one side of the face getting affected. Same side of the face getting affected, all the facial nerve weakness patient can getting. This is a Bell's palsy. Supranuclear lesion is happening means the opposite side. Opposite side, lower part of the face only affecting, not upper part of face, because upper part of face is escapes from this lesion because of bicortical innervation of the cerebral cortex. We can go per level of injury of the facial nerve courses. In case injury happened in the below the stylomastoid foramen, patient having the facial level paralysis in the muscles of facial expression getting affected this level. In case patient having affected in the above the cauda tympanic nerve branch, what happening means patient getting paralysis of muscles of facial expression and lack of salivation and loss of taste from anterior tooth of the tongue happening. In case injury happen above the nerve of stapedius, above the nerve of stapedius means patient including these lesions, patient having a loss of stapedial reflex happening. So patient having a slight sound also very loud. In case patient having a level of injury above the geniculate ganglion, so patient having this all the 5 problems: loss of lacrimation having, loss of stapedial reflex, loss of stage sensation from anterior to the tongue, lack of salivation, and paralysis of muscles of facial expression. These are all the things happening at the levels of facial nerve injuries. So these are the references of my topic. Thank you all for watching the video. Thank you.